Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, but we're going to be covering preeclampsia. So if you're taking maternity right now, or you're going to be taking it soon, this is a great video for you because I'm telling you, in maternity, you are going to get a lot of questions on preeclampsia. So it's something you're going to have to know well. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it. So go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already. Be sure to check out my website, nexusnursinginstitute.com. My calendar is now open for private one-on-one tutoring sessions. The first day of the open calendar, I want to say, is September 2nd, but don't quote me on that. You can also sign up for a next generation and I can't speak, next generation NCLEX review, both part 1, part 2. And part 1, I teach you how to think like the test writer. I teach you about phrases or situations that will be presented to you and exactly where your mind's supposed to go. And I teach you how to think, right? How to think critically. I teach you how to prioritize. I go over, priority and delegation. In part 2, we actually go over questions. They're not going to be the questions that you get on NCLEX, but they're going to be similar questions. And the only way I'm able to be so good at what I do is students like you. You go take your boards, you come back and you tell me, Professor D, I saw this, I saw that, da, 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 da. And so I kind of have a good idea, depending on the state that you're testing in, the content that you're most likely to see. I do not see that exam at all. I'm not guaranteeing you that you're going to get any questions because I've never seen the questions myself. However, I have a very good understanding of the type of questions you're most likely to see and the content that you need to be studying. So be sure to sign up for that if you're going to be taking your NCLEX soon. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, TikTok, Instagram, Facebook, right here, YouTube. My handle is the same everywhere, Nexus Nursing. And as I've been saying on the past couple of videos, just keep your eyes and ears open. Very soon, I'm going to be making an announcement about my new project that I'm rolling out. It's going to be the Nexus Nursing Test Bank, and it's going to be an opportunity for you as a nursing student to be able to go on my website and practice questions, the type of questions, the type of content that you expect to see on NCLEX, the things you better know. You're going to have that opportunity. And I'm actually going to be giving away 50 free memberships, 25 to LP and LVN students, 25 to RN students. It's going to be some type of I don't want to say competition. I hate that word, but I don't know. It's a award system. I'm just not sure how I'm going to do it yet. I'm still thinking about it. If you guys have any suggestions on how I should do it, like how I should do it, go ahead. Let me know in the comment section because I'm open for ideas. That's really not my thing. NCLEX is my thing, but I want to make it fun and I do want to do something to give back to you guys. So let me know in the comment section if you have any ideas. And guys, without any further ado, let's get started. Preeclampsia. All right, your patient's blood pressure is 145 over 92. The pulse is 86. The respirations are 14. Which information would cause you to suspect preeclampsia? Would it be a headache? Would it be hyperglycemia? Would it be proteinuria? Or would it be peripheral edema? Those are your patient's vitals. What would cause you to suspect preeclampsia? If you are not able to join the Kahoot, go ahead and type in your answer on the live. Very good. Proteinuria. Proteinuria. Here's the thing. For the patient to have preeclampsia, there are several characteristics that must be present. Number 1, hypertension. That blood pressure has to be higher than 140 over 90. Number 2, proteinuria. Protein needs to be present in the urine. Is protein ever supposed to be in the urine? Absolutely not. And number 3, the woman has to have surpassed 20 weeks of pregnancy, right? So it's been past 20 weeks, higher than 140 over 90, and proteinuria is present, okay? Headache, if the woman has a headache, most likely is due to what? That hypertension. Because let me tell you something, if it's been more than 20 weeks, the blood pressure is higher than 140 over 90, however, there's no proteinuria, it's not preeclampsia. She's got gestational hypertension. And that would be in addition to whatever symptoms, else she has going on. But if there's no protein in the urine, it cannot be classified as preeclampsia. That's very important for you to know. Hyperglycemia, that's diabetes mellitus, and peripheral edema. Peripheral edema, we see that often in patients who are pregnant. This is not diagnostic of preeclampsia. However, one last time, hypertension, proteinuria, past 20 weeks, preeclampsia, okay? All right, which statement indicates that the preeclamptic patient needs further teaching about fetal movements to report? Would it be, I'll report if the fetus becomes less active than before? I'll report if it takes longer each day for the fetus to move 10 times. I'll report if the fetus stops moving for 12 hours. I'll report if the fetus moves more than 3 to 4 times a day. Which statement indicates that the preeclamptic patient needs further teaching? All right, let's talk about this. Only 20 of you guys chose the correct answer. This is a problem. So, whenever you get a question asking you which one requires further teaching, which one requires clarification, which one requires further follow-up, that wording, really what they're asking you is which one's the wrong answer choice. And here, the wrong answer choice is the patient that says, I'll report if the fetus moves more often than 3 to 4 times a day. Why would you report that? That's a good thing. You only report things that are bad. There's nothing wrong with that. Why would we report that? So if the patient says that, that is the wrong thing. That's why we're choosing that, because the question asks us which one needs further teaching, further follow-up, further clarification, further investigation. We're looking for the wrong answer choice. All of the other options are good things to do. It's good to report if the fetus is less active than before, because if the fetus is less active than before, that's a problem. That's bad. So we want the patient to report that. It's good to report if it takes longer for the fetus to move each day. If it takes longer, something may be wrong. We want them to report that. We want them to report if the fetus stops moving for more than 12 hours. Maybe something's wrong, right? So we're looking for the wrong answer choice in this type of question. How are you guys doing on the live? Thank you. All right, next question. Your patient with severe preeclampsia is being treated with magnesium sulfate. What's a priority nursing intervention in this scenario? Is it to maintain continuous fetal monitoring? Is it to encourage loved ones to remain at the bedside? Is it to assess for reflexes, clonus, and vision? Or is it to monitor labs for elevated liver studies? Very good. To assess for reflexes, clonus, and vision. Think about it. We're giving magnesium sulfate. This patient has preeclampsia, and we do not want them to go into eclampsia. We don't want that patient to have seizures, right? So you're going to be checking for reflexes, clonus, and vision. So even though we don't want that patient going to seizures, we're also going to be concerned because we don't want them to go into mag sulfate toxicity where we're overcorrecting the patient and we gave them too much magnesium sulfate. Your student nurse needs further teaching when he says that preeclampsia can lead to what? Hydrocephalus, abruptio placentae, intrauterine growth restriction, decreased placental perfusion. Your student nurse needs further teaching when he says that preeclampsia can lead to what? Very good. Hydrocephalus. That's incorrect. That's a congenital abnormality, and that has nothing to do with preeclampsia. However, preeclampsia can lead to abruptio placenta, which is a medical emergency, by the way, guys. It can lead to intrauterine growth restriction. It can lead to decreased placental perfusion. It can lead to a stillbirth. This is very serious. Can you move the screen to the left a bit? Okay. Sorry about that. There you go. Select all that applies. Your patient is 28 weeks pregnant with gestational hypertension. Which finding would you immediately report to the healthcare provider? Select all that applies. Headache, pedal edema, blurred vision, proteinuria, fundal height of 28 centimeters, convulsions. Select all that applies. So your patient has gestational hypertension. Remember, I told you gestational hypertension, they're past the 20 weeks. Their blood pressure is higher than 140 over 90. However, there's no protein in the urine. So we can't call it preeclampsia. They're in gestational hypertension. They're in gestational hypertension. What would cause you to notify the healthcare provider immediately? Select all that applies. Hmm. So let's talk about it. I saw on the live, the game code is 783-3718. 783-3718. I saw someone on the live say that headache is expected. I want us to think critically right now. Your patient has gestational hypertension, so the blood pressure is high. A patient who's not pregnant, their blood pressure is high, and they have a headache. We are concerned. We don't want that patient to stroke out. So you mean to tell me the patient whose blood pressure is high and they're pregnant, we expect them to have a headache? Come on now. Absolutely not. Absolutely not. We're going to be concerned about that development of a headache. Pedal edema, no. And the reason why, again, with pedal edema, we see that in uncomplicated pregnancies. Blurred vision, absolutely. Proteinuria, absolutely. What are we thinking is happening here? Preeclampsia. We're thinking this patient has graduated from gestational hypertension to preeclampsia. Fundal height of 28 centimeters. Why? Why would we be concerned about that? Because we know once mom hits 20 weeks, that fundal height is going to be equal to however many weeks she is. So if she's 22 weeks, we expect that fundal height to be 22 centimeters. If she's 28 weeks, we expect it to be 28 centimeters. So there's nothing wrong with that. And of course, convulsions. Convulsions, that means that patient's gone into eclampsia, right? So those are what we would report, but not the pedal edema or the fundal height, which is appropriate for gestational age. All right, which item is most important to have in the room of a patient that's been diagnosed with severe preeclampsia? Here's your choices: an oxytocin infusion set, a disposable tongue blade, an ultrasound machine, or padded side rails. Everyone should get this right, as much as I've been talking. Very good. Padded side rails. Why padded side rails? We keep talking about preeclampsia, and we're so concerned about that patient becoming eclamptic. We're concerned about what? Seizures, right? Protect the patient. If they start having seizures, we don't want them to hit their head. We don't want them to injure themselves. Look at the other choices. 17 people chose oxytocin. That is a tocolytic agent, okay? That we would give that if we wanted to induce labor, if we wanted to cause muscle contractions. We don't in the patient with preeclampsia. Disposable tongue blades. I'm happy only 2 people chose that. But the 2 people who chose that, tell me what you were going to do with the tongue blade, because I know you weren't going to put it in their mouth. Because we don't put anything in anyone's mouth who's having a seizure. So what do we need that tongue blade for? And last, ultrasound machine, that great thing to have, but that's not going to be a priority. Not if we're concerned about a patient with. Here, I even gave you guys a clue. I could have just said the patient was had diagnosed with preeclampsia. Why did I put that word right here, this adjective severe, this descriptive word? Why did I put that? To let you know that it's bad. Let me tell you something. On your test, when you see severe in front of the noun, they're putting that word severe there for a reason. This is a huge concern. So the patient has severe preeclampsia. Yeah, it's very likely they're going to go into eclampsia. So what are we going to be concerned about? Seizures, padded side rails. Your patient with severe preeclampsia is receiving magnesium sulfate. Which drug should you confirm to be available or at the bedside? Would it be diazepam? Would it be hydralazine? Would it be calcium gluconate? Or would it be fenton? I can never pronounce that drug, but that's Dilantin. Very good. Calcium gluconate. That is an antidote. If your patient gets too much mag sulfate and they go into mag toxicity and you need to reverse it, you have to give them calcium gluconate. So you better make sure that there's calcium gluconate on hand if you're giving mag sulfate. Now, only 7 of you guys chose diazepam. That's an anti-anxiety medication. Only 7 of you, and I'm so happy. Only 7 of you guys chose hydralazine, which is an anti-hypertensive agent. I tried to trick you with the hydralazine. I put that in there because I wanted to see if you were going to think, okay, preeclampsia, hypertension. I wanted to see if that's where you were going to go, but I'm happy you didn't fall for it, because at the end of the day, what are we talking about? Magnesium sulfate. So whenever you see a drug, you have to think about the action of the drug, okay? And what can happen if it works a little bit too well. And last, the Dilantin, that's the anti-convulsant agent, right? It stops seizures. It treats seizures. So when it comes to mag sulfate, you're going to make sure that there's calcium gluconate available on hand at the bedside in case the patient needs an antidote. Before I move on to the next screen, something I didn't ask a question on, but NCLEX definitely asked about it. And if you're in the nursing program, you're taking maternity right now, most likely you'll get a question on this as well. So let me just say it, even though I didn't make a question on it, I do want you guys to know this. What do I want you to know? What was I thinking about? Oh, okay. Magnesium sulfate. We give magnesium sulfate to prevent that patient from going into seizures, into convulsing. That's why we're giving that magnesium sulfate, okay? Yes, magnesium sulfate brings down the blood pressure, but we will never give magnesium sulfate strictly to bring down the blood pressure. Why? Magnesium sulfate, number 1, has a very narrow therapeutic range, and number 2, is very dangerous. There are so many safer drugs on the market that we can give the patient if we just want to bring down the blood pressure, right? So yes, it has a wonderful side effect of bringing down the blood pressure, which we want to happen, but that is never the indication to give magnesium sulfate. We're giving magnesium sulfate to prevent the seizures, not to bring down the blood pressure. Yes, it does bring down the blood pressure. Yes, we're happy about it, but that's never the indication. And I'm telling you, don't fall for it. If you see it as a question, I'm telling you right now, if you choose magnesium sulfate as an antihypertensive agent, you're going to get that question wrong. Don't say I didn't warn you. All right, your patient's receiving mag sulfate. Which clinical manifestation would cause you to suspect hypermagnesemia? So what would cause you to suspect that the patient's getting toxic level of magnesium sulfate in their body? Would it be decreased deep tendon reflexes? Would it be cool skin temperature? Would it be tachycardia? Or would it be paresthesia? And everyone should get this right, because in my last explanation, I told you what mag sulfate does. Think about it. Very good. Most of you guys got the correct answer. Decrease deep tendon reflexes. And that's how it helps the patient not have seizures, because when the patient's having seizures, what do you think the muscles do? Do you think they relax or they contract? They contract. So if the patient's getting too much mag sulfate, guess what? They may have hypoactive deep tendon reflexes. We may see that blood pressure drop too low. We may see the respirations go down. So you got to be very careful, okay? Now, cool skin temp, tachycardia, we may see that with the opposite. We may see that with hypomagnesemia. And last, paresthesia. When do we see paresthesia? Paresthesia, I can't pronounce, guys. I'm sorry. If you're new to my channel, I have a speech impediment. I've had it since I was born. I'm so sorry. A lot of things is hard for me. I have it in my brain, but it's hard to come out of my mouth. But I'm not an idiot. I promise. I know what I'm talking about. Paresthesia. Okay, you see the word. Anyway, that means like prickly sensation, like the patient feels like pins and needles, right? That sensation, that paresthesia, you get that with hypocalcemia. Hypocalcemia. All right. Very good, Queen of the Jungle. Yes, also diabetic neuropathy. Correct. All right, your patient with preeclampsia starts to have a seizure. Which action will you take first? Are you going to insert an airway to improve oxygenation? Are you going to look at the time to note when the seizure starts and ends? Are you going to call for help, or are you going to turn the patient to the left side? Wow. 90. Let me calm down. So you have a preeclamptic patient and they start to have a seizure. The first action that you take, listen, guys, it takes 2 seconds to scream for help at the top of your lungs. It takes 2 seconds. Matter of fact, let me walk this through with you. Your patient has a seizure. If they're standing up or sitting down, you're going to ease them onto the ground, and you scream for help first. You scream for help. You're by yourself. You scream for help. You ease them onto the ground. As you're easing them onto the ground, you look at the time. You want to see what time their seizure started. We don't care about the onset. The reason you're looking at the time is not for the onset. You're looking at the time, so after the seizure, you can look at the time again so you can know the duration. The healthcare provider bases their treatment on that patient. One of the most important things is the duration and the type of seizure that they had, and you are the only witness. All right. So you scream for help, you're easing them onto the ground, you look at the time, you get them on the ground, you turn them to their left side. After you turn them to their left side, you put a pillow under their head. Professor D, why do I turn them to the left side before the pillow? Airway, breathing, circulation. Who cares about protecting their brain if they're dead, right? We need oxygen to go to the brain, so we have to put them on their left side. Then we put the pillow under their head. After that, we loosen restrictive clothing. We move everything out of the way so that they can have their seizure freely and not injure themselves. We close the curtain because you have to allow that patient to have their privacy. You watch that patient have the seizure. After the seizure, immediately, because sometimes that seizure is very strong, they may turn over. If you have to turn them back to their left side after the seizure because you want to prevent aspiration, you do that again. You help the patient get into the bed. You put the bed in Lord's position. You put the side rails up. You reorient that patient while you're taking their vitals. You take their vitals. The very last thing that you do is call the healthcare provider. Why? Because everything that led up to that, you call in the healthcare provider, you have to report to the healthcare provider. All right. But the very first thing you do, if you see the option of calling for help, that is the first thing that you do. Right? And NCLEX is fair. Let me say this, NCLEX is fair. If you have that option of call for help, you're not going to see the turn the patient to the left side. You're going to see one or the other. I've yet to get feedback, because I don't see NCLEX myself, but I've yet to get feedback from a student saying they saw both at the same time. And I've been doing this for a very long time. NCLEX is very fair. You're going to get one or the other. Now, if call for help was not an answer choice, then yes, of course, you're going to turn that patient to their left side. But NCLEX wants to see, do you understand this is an emergency? You need help. The first thing you're going to do is scream for help. It takes 2 seconds. Turn that patient on the left side. Winnie Brown 891 says makes sense. Okay. That's right. Secure the airway. The PIN is 783-3718. 783-3718. Guys, can you type it in the comment section for the newcomers, please? Thank you. Next question. All right, you just gave hydralazine to your patient with severe preeclampsia. You would assess that patient for what? Would you assess them for increased heart rate, decreased respirations? I spelled respirations wrong, sorry. Increased urination or difficulty swallowing. You just gave hydralazine to your patient with preeclampsia. What would you assess them for? Increased heart rate. An adverse effect of hydralazine is a wonderful drug. It's a wonderful anti-hypertensive agent. But let me tell you something. We don't give hydralazine willy-nilly. So someone has normal, simple hypertension. We're not giving hydralazine. Hydralazine is the big guns of the anti-hypertensive agents, right? So if a patient with severe preeclampsia, they're going to get hydralazine. But the thing is, an adverse effect is tachycardia. Your heart rate's supposed to be 60 to 100, so hydralazine could cause that heart rate to surpass 100, so we have to be careful about that. So guys, when you get a test question, and in the question, it tells you that you either just gave a drug and they give you the name of the drug, or they tell you that you're preparing to give a drug. Listen to me, please. Lock in to what I'm about to say to you, and this is going to save a lot of you. Do not focus on the diagnosis. You notice how I said you just gave hydralazine to the patient with severe preeclampsia, right? Whatever answer that you choose has to go towards the hydralazine, not the diagnosis of preeclampsia. And this is what NCLEX does. NCLEX will tell you, and in nursing school too, if you're in the nursing program, same thing. They will tell you, you either just gave this drug or you're preparing to give this drug, and then they tell you what the patient's diagnosis is. That diagnosis is, what's the word? Distractor. That's the word I'm looking for. It's a distractor. When you focus on the diagnosis for your answer, you're going to get the answer wrong. You have to focus on that drug that you either just gave or that you're preparing to give. So what do I mean by that? The 3 top things. Either the adverse effect of the drug, which means, by the way, there's a difference between side effect and adverse effect. Side effect is something that may potentially happen, and you teach the patient that it may happen. You warn them because you don't want them to stop taking the drug, right? Adverse effect is something that may potentially happen, but you do not want to happen under any circumstances. And you warn them, if it happens, you have to let us know right away. Why? The healthcare provider is going to have to do something. They're probably going to change the medication, change the dosage, something, right? So very often, a side effect and adverse effect is used interchangeably, but they're not the same thing. Adverse effect is much worse. Like if you look in your drug book, adverse effect is the text is going to be in red, and the side effects would be in black, right? Anyway, I just went off on a tangent. What was my point? Oh, back to my point. So when it comes to drugs, you're looking for either adverse effect of the drug, the nursing intervention for the drug. So if you give something like hydralazine, if hydralazine works a little too well, your patient could bottom out. You might cause them to be hypotensive, right? So what would your nursing interventions be? You're going to teach a patient, don't try to get up by yourself. If you got to get up to go to the bathroom, press the call bell, stuff like that. You're going to have them dangle, all that good stuff. And the third thing when it comes to drugs, so what did I tell you? Adverse effect, nursing intervention. What's the third thing you got to know when it comes to drugs? Oh, indication. And out of the three things I just said to you, indication is the easiest. Why is this drug being given? And this new next generation NCLEX asks more questions about the drug indications than the old one. And indication's easy. All you got to know is why this drug is being given, right? So please, when you guys are studying your drugs, focus on those three things, because 95% of the time when you get a question about the drug, that's really what you're being questioned about. Either the adverse effect of the drug, your nursing intervention for that drug, if that drug works a little bit too well, what can happen, what you're going to do, what you're going to teach a patient, and the indication, why that patient is taking that particular drug. All right. Your patient has preeclampsia. Which symptom would cause you to suspect that they're about to have a seizure? Would it be hypoactive deep tendon reflexes? Would it be hypothermia? Would it be hypotension? Or would it be epigastric pain? You guys are killing me on this live. Let's think about this. I want you guys to think. Your patient has preeclampsia. So that means their blood pressure is higher than 140/90. They're past that 20 weeks gestation, and there's protein in the urine. They've got proteinuria. Our big concern now, we want to prevent them from going from pre-eclampsia to actual eclampsia where they're having seizures. Think about it. What are seizures? Your body is convulsing. What are your muscles doing? Contracting very strongly. Out of these choices I gave you, which one is the only one where you see the freaking muscles contract? I'm so upset I can't even speak. You see the muscles contract strongly. Epigastric pain. How you going to choose hypoactive deep tendon reflexes? Do you understand what hypoactive means? Hypo means a little bit of, active reflexes. That means the muscles contracting just a little bit. Moving on. I'm sorry, I didn't mean to yell. You guys know I love you. I want you to do well on your exams, guys. You got to think. You guys got to think, because nursing really isn't hard. It's just tricky. Ooh, we're almost done. Thank you. What are the risk factors for preeclampsia? Select all that apply. What are the risk factors for preeclampsia? Here are the choices. Nulliparity, being older than 40 years of age, having a family history of preeclampsia, being a woman born small for gestational age, being obese, having multifetal gestation. What are the risk factors for preeclampsia? Select all that apply. Thank you. I love you guys too. Not too much on us, Professor D. I'm trying. But in all seriousness, this is where I want you to make the mistakes. Make the mistakes with me. So when you're sitting in front of that test, you choose the correct answer and you're confident. You know why you're choosing the correct answer. As much as I yell at you, I love you guys. I'd rather you make all your mistakes with me so you don't have to do it on the test. All right. The risk factor, and there are more risk factors than these that I put on the board, but these are the ones that NCLEX most commonly uses as options, and nursing programs, because at the end of the day, guys, if you're in a nursing program, you're being prepared to pass NCLEX. So these are the ones that I tend to see are used the most, but this list is not all inclusive. Nulliparity, yes. What is nulliparity? Having never given birth, having never had a live delivery. So you gave birth and the baby was alive. So nulliparity, that is a risk factor for preeclampsia. Being older than 40, yes, that's a risk factor. Family history of preeclampsia, absolutely. Being born small for gestational age, yes. Being obese and having multifetal gestation, what does that mean? Carrying twins or triplets, or what's that called when you have four? Twins, quadruplets? Qu is four quadruplets? I feel like it is, but quads. Quads. Quads? Oh, okay. Quads. Oh, quadruplets. I said it wrong. I said quadruplet. You know what I mean, right? So having more than one fetus in the womb, that is also a risk factor. All right, last one. Which deep tendon reflex response is considered to be normal? 0, +1, +2, +3, +4, or +5? Which one is considered to be normal? Quadruplet. Okay. Which deep tendon reflex is considered to be normal? All right. 2. 2 is normal. This is active. This is an expected response. 0 is bad. That means there's no response whatsoever, right? That's hypoactive. +1 also is hypoactive. The response is sluggish, right? 2 is normal. 3 is slightly hyperactive. 4, absolutely, it's hyperactive, it's brisk. And 5, I just made that up. That's not even an option, right? So normal response is your +2. And guys, that is the end of preeclampsia, but there's so much more that I could have covered, but I really want to make sure. I think I'm going to do more on this topic because preeclampsia is one of those in maternity you'll get a lot of questions on. So you got to know it. It's not one of those things you refuse to learn and just hope you don't see it again. You're going to see it again. So I think I'm going to maybe do another Kahoot or two on this subject. But anyway, those of you who are watching this on YouTube, go ahead, let me know in the comment section what you thought about this video, what you'd like to see me cover next or on the next Kahoot. And don't forget, keep your eyes and ears open. Very soon, I'm going to be rolling out my Nexus Nursing Test Bank for the students who are going to be taking NCLEX, and you really want to make sure you're prepared. You want to make sure that you studied everything you were supposed to study. I got you. I'm going to be giving away 50 memberships, 25 to LP and LVN students and 25 to RN students. It's going to be like a competition. I'm not sure how I'm going to do that yet. Also in the comment section, if you have an idea of type of campaign I should run or what type of competition be, go ahead, let me know. I'm open to ideas because my specialty is NCLEX and nursing. It is not competition. So if you have an idea, go ahead, let me know in the comment section. For you guys on the live, let's see how you did.